Good morning, good afternoon, good night. It is a pleasure to be chairing this epidemic ethics virtual seminar on vulnerability and othering during the COVID-19 pandemic. It is my pleasure. Well, I will introduce myself. I'm Dr. Florencia Luna. I'm principal researcher at CONICET, the National and Technological Research Council at Argentina. And I'm the director of the program of bioethics at Flaxo, Argentina. I was president of the Association of Bioethics during 2003 and 2005. And member of the steering committee of the Global Forum, and I've been working a lot on vulnerability, basically. So I won't read all my CV, but I do want to introduce my colleagues here in the panel, very recognized. Dr. Tamara Giles-Wernick. She's director of research and head of the Anthropology and Ecology of Disease Emergency Unit, the Institut Pasteur, first social science research unit. She coordinates SNARR Global, a European Commission funded global social science research network for preparedness and response to infectious threats. A specialist in the medical anthropology and history of Central and West Africa. Her current research focuses on COVID-19 and its consequences, and she serves as a member of WHO COVID-19 Social Science Technical Working Group since 2020. Her other research brings together anthropological, historical, ecological, and metagenomic approaches to the emergence of zoonotic diseases and epidemics in Central Africa. In addition, she has published on viral hepatitis, Ebola, Burugh ulcer, the historical emergence of HIV in Africa, global health in Africa, the history of influenza pandemics, and environmental history. We also have with us Professor Thomas Shakespeare, who was trained in social and political science at Cambridge University and subsequently studied for MPhil and PhD. He has taught and researched at the University of Sunderland, Leeds, Newcastle, and East Anglia. And from 2008 to 2013, was a technical officer of the World Health Organization in Geneva, where he co-authored and co-edited the World Report on Disability and International Perspectives on Spinal Cord Injury. His books include The Sexual Politics of Disability, Disability Rights and Wrongs, Disability, the Basic. He was a member of Arts Council England from 2003-2008, and the NAFLD Council on Bioethics from 2013 to 2019. He's currently chair of Light for the World, UK, and vice chair of Light for the World International. And finally, last but not least, Dr. Aksa Saik is a community medicine specialist with an interest in COVID-19 surveillance, vaccination, and research. She has been interested in medical education, technology, and medical humanities. She's India's first and only nodal officer of COVID-19 Vaccination Center. Aksa has penned numerous books on subject matters besides contributing essays and chapters. She also blogs on issues of social interest, and welcome you all to this very interesting panel where we will discuss issues related to COVID-19, vulnerability, and othering. So as it will be interesting to have the time for questions and all that, what we will do before starting, I should ensure that you use the chat function only to say hello. But if you want to send us questions, please use the Q&A. And if there are questions already that you like them, please mark them so we know which are the preferred ones. And this session is being recorded, and this will be available as soon as we can. So I was saying that we are going to speak about vulnerability and the concepts of also othering. So maybe what we will do is we will begin by my presentation, which begins with the more theoretical, maybe, way of considering vulnerability. So my presentation says vulnerability, why the right conceptualization matters. And that's what I will try to show in these few slides, because that's mainly what I've been doing in bioethics. I come from philosophy. I do theory. And I work on these kind of things, and I will try to show why it is important to have the right conceptualization. In this presentation, I will explain why having a good conceptualization of the concept of vulnerability is important. As sometimes it is felt that like theory is very aside or not important, I will try to show that it is not the case, and that maybe a good conceptualization of what is vulnerability is important. So I will present first the traditional approach. I will explain some of the problems it faces and the difficulties in practice. I will then sketch my approach to solve the problems, and then I will give some examples. So it is based in, the traditional approach is based in this idea of subpopulations, racial minorities, the very sick, the institutionalized. This was, for example, the view at the Belmont, or as I put down the SIOMS in the 2002 version, SIOMS WHO guidelines that were re-edited in 2016, changed and took the view I'm endorsing and I'm proposing. So with this view, the tendency is to have like an overpopulation of vulnerable populations. What is the problem? This problem of subpopulation has the problem that it stereotypes. This implies putting someone a label that this group of or this person is vulnerable, and that cannot taken out. It fixes the content, and it cannot be easily changed. It may identify subpopulations that may not be vulnerable, or vice versa, as we will see. And for example, in this very interesting article, Carol Levine and colleagues said it is an irrelevant concept. The concept is so nebulous that it becomes at most meaningless. It is so broad that in one way or another, everybody is vulnerable. So this was the view that was sustained, this idea that there are vulnerable populations, and when we began naming them, we had a lot of populations that enter this category. And it has this characteristic that once you label someone or a group as vulnerable, it was very difficult to take it out. So let's go to the next one. So what I did in 2004 or 2009 I propose in this article a different approach. And what I said was that the functioning of this, that it is a very important concept. We have to retain it, and that this concept is relational and dynamic, that it interacts with the context, and that we should not think in categories, in mere layers, labels, but in layers. So what I propose is what I call the metaphor of layers. And as I will show in the next slide, please, what I try to defend is the idea that there are several layers of vulnerability, that there is not one layer or condition that may exhaust the whole category. So there are multiple different, some related to the lack of consent, to socioeconomic conditions, age, gender, the context, and different layers may coexist. As well, they can be minimized one by one. And if we come back to this idea of the pandemic, we can see that this idea of subpopulations pointed mostly, and at the beginning, to what was the elderly people that would be the major target of COVID-19. However, what was seen quite soon was, for example, that Afro-American First Nations people suffered a lot due to, for example, their socioeconomic status, comorbidities, gender. So if we begin thinking in layers, we can get more easily to this group of persons that are suffering different kinds of layers. As well, during the pandemic, we saw that some physicians were also vulnerable. But if we are working with this idea of layers, we can say, well, they acquire one layer of vulnerability. And we will see that this conception of vulnerability as being dynamic and flexible makes room to situations or public policies that, for example, make it worsen or decrease or avoid vulnerabilities. So there are other relevant distinctions. I worked in another article like 10 years later. So this is a concept I've been working for very many years, and where I spoke of how the structure of layers of vulnerabilities are. And what I explain is that layers of vulnerabilities are dispositions. They are latent until a stimulus condition triggers them. And this is very important. It's like, for example, in philosophy, we speak of a cube of sugar that is soluble, and it dissolves when it is introduced in a liquid. The stimulus condition is the event of introducing it in liquid. It triggers solubility. If that stimulus condition or that trigger does not happen, that layer will never occur, will never be actual. So, for example, this is a very interesting concept in order to think how to prevent, avoid, minimize layers of vulnerability. So, for example, in the case of physicians, lacking protective equipment and vaccines for medical staff could trigger that layer of vulnerability I was speaking in the previous slide. And this was relevant for physicians, for example, in developing countries. So this explains why some physicians in industrialized countries were not vulnerable in a way that physicians that were working in other conditions without protective equipment or without having been vaccinated were obviously put in risk, and thus they were vulnerable. So this idea of triggers is quite fundamental. Let's go to the next one. Another important distinction I want to point out is that certain layers may exacerbate existing vulnerabilities or generate new vulnerabilities. I think they're harmful. They're harmful, and they have these replication powers, which is very relevant. And I name them as cascade layers of vulnerability. And for example, in public policies, isolation in the case of informal workers can have this cascade layer effect. For example, not being able to work, to bring money, to have to eat. So this kind of layers have this triggering and this cascading effect. Another situation, for example, has to do with isolations in the case of women and teenagers living in situations of violence. So being in isolation will bring a cascade of different vulnerabilities. So this idea of cascade vulnerability is also quite relevant. This table where I try to show how should we work with this concept. So what I try to show here is that we have to identify and evaluate these layers, and we can rank the layers and prioritize following some of the ideas I was pointing out in the previous slides. So the idea is to prioritize from major to minor harms, to consider this cascading effect, considering which are these layers that are very harmful and very probable, and how to consider, for example, as I was showing with the case of physicians, triggers, possible triggers or stimulus conditions, and this will lead to different kinds of obligations. So I put in the table, one is avoiding exacerbating layers, eradicating layers, or sometimes we cannot eradicate layers. These are situations where, for example, we have these informal workers and we cannot eradicate these situations. So what we will do is try to minimize layers of vulnerability. So having policies that will contemplate the case of informal workers and how to help them stay at home, or bring them food or things or other policies that may help deal with these very difficult situations. So this will be the case of minimizing layers of vulnerabilities. And how can we do that? Well, we can do that through different strategies, by protections, safeguards, and empowerments. I won't go through all the details. I think that in one of the slides, I put you the reference if you want to see it, as I'm running out of time. So the next slide, and I will try to finish soon. So I think this model gives an order to evaluation. It helps assessing harms and risks. Cascade layers acquire relevance because of their strength and harmful power. Stimulus conditions are also relevant as they point to the probable occurrence of vulnerability. And different obligations can be fulfilled through protections and safeguard, but also through empowerment and generation of autonomy. So the last slide, what are the benefits of this proposal? I think it uses the flexibility and dynamism of layers, describes better what happens in the real world, and can address complexities. the normative force devastating and incremental harms implied by cascade layers, and the possibility of harmful layers are underscored in this model. And identification of stimulus conditions or triggers are outlined and help a better evaluation. I think it gives concrete guidance, and in this sense, it might be helpful. Thanks a lot, and sorry that I took more time than I thought, and I will give the table to Dr. Tamara Giles-Vernick.
Hi, thank you so much. I want to thank the organizers for inviting me, and I'm really looking forward to hearing from my colleagues, and also thanking Dr. Florencia Luna for her really brilliant remarks. So I'm going to share my slides and then try very hard to, begin.
Maybe you could do as we did, continue
okay.
like that.
I will do this very, very quickly. Okay, so let's go to the next slide. So as a way of just kind of getting started, I want to first of all say I am not a bioethicist, and I would not even consider myself necessarily a specialist on vulnerability, but what I'd like to do is present some reflections and insights based on a vulnerability and resilience assessment that the Sonar Global project conducted in 2020 and 2021. Now, the Sonar Global project and consortium is a European funded project, European Commission funded project, which it's a network of social sciences for preparedness and response to epidemics in AMR. And we have 15 partners worldwide and a whole series of regional hubs. Now, originally, when we began in 2019, we'd already planned to conduct this vulnerability and resilience assessment in Uganda and in Bangladesh with our partners Makerere University and Brock School of Public Health. But with the just eruption of the COVID-19 pandemic, the EC asked us to do more COVID-related work to understand the consequences of this pandemic and its measures for European populations. So globally, our objectives in these 7 countries were to identify local cross-cutting factors that reduced or augmented marginalization and exclusion in the pandemic, to identify new processes of marginalization and exclusion, and most important, I think, to take the results of those assessments and really working in close collaboration with key structures, organizations, on-the-ground actors, develop and implement policy recommendations. So just to give you a sense of the method itself, this is, again, I take an ethnographic approach. So there are actually, I think I was really fascinated by Dr. Luna's presentation. I think that there's some really interesting convergences here. But what this is again, a qualitative tool that includes a 52-point health and demographic data questionnaire, as well as a semi-structured, detailed, and I really mean detailed, these things can take up to 3 hours to do, interview guide that looks at health, well-being, risks and experiences of COVID-19 through 3 different sections: knowledge and experiences of aid and assistance in the formal sector, knowledge and experiences of aid and assistance in a kind of informal and community sector, plus a whole series of questions about livelihood, food practices, health practices, and the like. And a 3rd section on standard indicators of vulnerability. So looking at questions of trust, the person's sense of isolation, their perceived ability to manage their health, and the like. The recruitment took place as often as possible through snowballing, so that we would ask participants if they knew of other people who might like to share their experiences, who might have had a difficult time during the pandemic and in subsequent times, which enabled us to move in effect beyond labeling specific and identifying specific groups, in fact, to highlight the kinds of hidden fragilities, the less visible factors of marginalization, as well as specific social groups that had not been sort of classically understood as vulnerable and yet were vulnerabilized by these by the pandemic. So this is a qualitative approach that's not designed to develop any kind of statistically representative samples, but rather to illustrate a range of experiences, how and why people were marginalized in some way by the COVID pandemic, by control measures. And so this is just an example of, during part of the the demographic data questionnaire, somebody talking, a nurse in a nursing home, talking about whether she sleeps well, and really begins in this absolutely extraordinarily moving description of what it was like for her at the beginning of the pandemic. So this is just, I'm just going to move through this very quickly. These are the locations in which we conducted the vulnerability and resilience assessments. These are some of the leaders involved, and you can take a look at some of the policy briefs on our website. So how do we talk about, how do we think about the needs of people who are at greater or greatest risk from infectious disease threats? Vulnerability is a really debated term, and I think, and I would fully agree with Dr. Luna, that we need to move beyond this notion of identifying and labeling specific vulnerable groups. I'm just flashing up very quickly, recognizing that it would probably take the rest of the hour to describe it, but David Napier and Anna Volkmann's vulnerability vortex. Now, the reason that I'm putting this up is that they were the developers of this vulnerability assessment at University College London. They're a partner within Sonar Global, and they've been really, in effect, the kind of drivers behind this. So the idea here is that as populations are destabilized by epidemics and other shocks, their agencies, their capacity to act and make those actions felt in the world are reduced. Their social exclusion is increased. Their trust is decreased, and they are thus more at risk, more focused on securing the basic necessities of life, less able to engage in certain kinds of behavior change guidelines. But this is dynamic. And like Dr. Luna, they're really thinking about how people can move in and out of these situations. So it's flexible and dynamic. What the point is, the point of departure here is that all people are potentially vulnerable, facing transversal, complex, and compounding factors that render them increasingly marginalized and excluded. So this kind of ethnographic bottom-up approach is crucial to understanding how people can, in effect, regain some aspects of their agency. So resilience, by the same token, is about enhancing or possessing or enhancing certain kinds of capacities to cope with these challenges. What each of the partners, the 7 partners engaging in this vulnerability and resilience assessment did was engaged in multi-scalar, multi-sectoral engagement. Now, everybody's talking about community engagement these days. What these partners, including the group that I coordinated, Institut Pasteur, did was work closely with national, municipal, and association and other kinds of actors from the beginning of our activities, not only to feed to them the kinds of ongoing insights that we developed over time, but to co-develop policies alongside them. So just in a couple of examples of stigmatizing and discriminatory discourses, one comes from, for instance, our Slovenian partner who conducted, I think, almost 200, not over 200 interviews. The myth of the contagious migrant. So the idea was that, or the myth here was that it was migrants who at the beginning of the pandemic were bringing COVID-19 into Slovenia, even though epidemiologically we know that it was business travelers throughout Europe, vacationing skiers in Italy and in other locations, basically going away and bringing back, being infected with COVID and introducing it to other populations back in their home countries. What happened in Slovenia was that asylum seekers arriving in country would find themselves enclosed in rooms of 20 people without any kind of facilities between 1 and 3 days, which in fact probably facilitated the transmission of this disease and was just basically traumatic. In Malta, another example was that the state developed a legal category of vulnerable populations at the beginning of the pandemic, with orders that those people should isolate themselves. But when it was pointed out, in fact, that this was a kind of stigmatizing and discriminatory practice, the state had to step back and reverse this measure.
Tamara?
Yes.
10 minutes.
Yeah. No, I'm just going to finish. So how do we move beyond
Perfect.
vulnerable groups? Health is made and broken outside of the health sector. All people are potentially at risk. We need to focus on resilience, and I will just leave it at that since I'm over time. Thank you.
Perfect. Perfect timing. Thanks a lot, Dr. Tamara. And we will pass then to Professor Thomas Shakespeare. And he's...
Hi there. Thank you very much. I don't have a PowerPoint, luckily. I will talk particularly about disabled people. And I worry that the idea that everybody is vulnerable feels banal, because in practice, that's not what actually happens. When we see who dies, there are particular groups. So in Scotland, people with learning disability were twice as likely to have severe COVID symptoms, 3 times more likely to die in 2020. In England, data from the Open Safety Platform showed that people with learning disabilities had an 8.2 higher rate of COVID-related deaths in the first wave and a 7.2-fold higher related death during the second wave. The data from the LEADER review indicated that 35% of people with learning disabilities who died from COVID lived in residential settings. And there are many problems accessing tests, learning disability nurses, and other support. Baksh found that people with learning disabilities were more likely to present with severe illness at the point of admission, late presentation to hospital, poor symptom recognition, communication difficulties, exclusion from disability digital information campaigns. So we're talking about are disabled people generally, and people with learning difficulties in particular, an afterthought, a lack of thought, or no thought. And the data I presented is from Britain, but that's because we have data. Most places don't have data, but I would argue that it's probably as bad or worse in other places. So what conceptual framework can we use? Courtney and Cooper in their editorial from BMJ talks about the extreme vulnerability of people with learning disability, in particular to COVID-19, levels of comorbidity and clinical vulnerability. And this was challenged by Chris Hatton, who didn't like the use of the word vulnerable. And he said that removed agency. And in fact, it's about how society treats disabled people, people with learning disabilities. And according to Chris Hatton, it's this treatment that makes people particularly vulnerable. So I think there is an important debate here, how much it is intrinsic and how much it is contextual, if you like. And I would turn to Martha Feynman, who talks about vulnerabilities being embedded in social relationships and within social institutions. So yes, there are embodied differences arising from biology or social relations or whatever, categories such as ethnicity, gender, and disability, how these have been constructed to create hierarchies and bias. And of course, people with intellectual disabilities in particular have been marked as incapable, inferior, weak, or dangerous. And this is not universal, it's socially imposed, it's contingent, it takes many forms. But then there are embedded differences arising from economic, social, cultural, and institutional relationships. So rather than looking at individuals, we should look at context, we look at structures that cause vulnerability, that make people vulnerable. So I just want to go through a few, and this draws on data from Morgan Banks has led a program of work in Vietnam, India, Bangladesh, Turkey, and Zambia. So it's based on qualitative interviews. So what have we found? We found that access to information is a big challenge in all settings. And even when states provided some accessible information, it was inconsistent, it wasn't well delivered, there were regional variations, for example, in sign language, which are not recognized, also all sorts of problems. There are issues about vaccination, misconceptions, hesitancy that arises from disability, that people felt they were more at risk of side effects and so forth. In terms of employment, we know that people before COVID-19, people with disabilities are more likely to work in informal sector. They're more face-to-face interactions, and therefore people with disabilities face more severe income losses during the pandemic because of lockdown and curfew social distancing. I'll give you an example of the work we did in Zimbabwe with people with psychosis. Most of them were day workers. They're working in people's homes as cooks or cleaners or gardeners or whatever. And of course, people were working from home during lockdown. They didn't need to pay these people, and they dispensed with them in many cases. So they're unemployed. Supply chain disruptions have disrupted self-employment. Many of the workarounds, for example, going to other cities to find work or supplies, were very much more difficult for people with mobility limitations. In a survey we did in 3 largest cities of Vietnam, people with disabilities were 3 times more likely to report having lost their job during a pandemic, 20% more likely to report that their household income had decreased. And of course, in many countries, we have a rising inflation, reducing standard of living. And of course, people with disabilities are more marginal. People with disabilities felt that they were at higher risk of COVID-19, took additional measures than recommended guidelines. For example, didn't go outside, self-isolated. I think this is particularly common for carers of children with disabilities. In many cases, children's social activities were completely cut due to a fear of the child getting affected, or indeed that they would be stigmatized because the child was unable to follow guidelines. And so in addition, it added stress from the pandemic. For example, other household members losing their job or financial strain on household budgets leads to increased tension between people with disabilities and other family members, particularly people with disabilities who are not working. And there are reports we've had of increased discrimination and violence. Finally, talking about disabled people's organizations, I think they played crucial roles in the pandemic, often taking on responsibilities that are typically the role of the state. For example, providing information in accessible formats, providing temporary emergency food, providing personal protective equipment and other assistance. But of course, the reach of disabled people's organizations are limited. They're particularly active in big cities. They may not reach rural areas or people who are particularly disadvantaged. And in fact, we have just submitted a paper which finds that only 10% of disabled people are in organizations of people with disabilities. So I would argue, and I can go on in greater detail in terms of Britain, that people are very, very much more excluded if they're disabled and face a lot of barriers. Thank you, I'll finish there.
Thank you very much, Tom, and thanks for being on time. It's very interesting. I hope we have some time for debate, and very interesting, I think, the perspective of action and being there. So, Dr. Aksa, it's your time.
I hope the slides are visible.
Yeah.
Yeah. Oh, thank you. So I'm Dr. Aksa Sheikh from Delhi, India. And while the previous speaker spoke about inequities in general and specifically to the persons with disability and persons from low and middle income countries when it comes to infectious diseases, I'll be focusing more on transgender and gender non-binary communities from India who have extreme vulnerability when it comes to pandemics and the services that are provided to tide over the pandemic. I would also like to talk about the research that we are doing, supported by Sabin Vaccine Institute, on trying to understand the impact of historical and entrenched structural inequities, especially when it comes to access to the COVID-19 vaccine and uptake amongst the trans and disabled communities in India. I am myself a trans woman and have the lived experience of being a trans healthcare provider during the pandemic, and I would like to highlight on those aspects. So India, which is home to 135 crores or 1.3 billion population, has nearly 500,000 official count of trans persons, though the actual count is much higher. And most of the trans persons in India have been historically into professions like begging, sex work, or blessing children and couples on marriages and childbirth. When it comes to the TGNB community in India, it has been traditionally at a higher risk of infection and mortality because of the challenges in accessing the COVID-19 vaccination services, unaffordability, unavailability, the historical marginalization that the community has had, and all this only got exacerbated when the pandemic struck. What is also very interesting to note is, apart from the lack of access to its services, there was increase in domestic violence, conversion therapy, where trans folks and queer folks were forced into harmful and sometimes nearly fatal conversion therapy, corrective rapes, especially for lesbian women and trans men, and even forced marriages, sometimes of children, during the pandemic time. Most of the trans folks who were involved in begging as a traditional profession said that no one wanted to give them money. I'm just using one of the quotes from the community members, as people were not even ready to roll down their car windows, forget about having any form of contact or speaking with them. And people were not inviting them to any form of the functions which were used as a means of giving blessings and therefore taking money. Also, the general healthcare was completely disrupted, and a lot of trans folks could not even access general healthcare. Also, the HIV preventive and treatment services in the forms of condom provisions and antiretroviral therapy suffered a setback. Most of the trans persons do need some form of mental health services, and they were also not very readily available. We know that COVID-19, when it comes to India, it's one of the most severely affected country. According to the latest WHO data, the most deaths from COVID happened in India, though India contests that number, and therefore we don't really even have the official count of people who have died of COVID in India. When it comes to COVID-19 vaccination, started almost 1.5 years back. And all the adults are eligible for getting COVID vaccines and the booster shots. But when it comes to trans folks, we do not even have data on the number of trans people who have been vaccinated. Also, there has been a lot of reports of fear and hesitancy amongst the trans community because of the approach of the service providers and how the vaccination drive literally left out the trans folks from India. Now, when it comes to vaccine hesitancy, or I would rather call it as lack of access to the vaccines in the trans community, it's because of the historic experiences that the community has with the Indian healthcare system, which has been traumatic and transphobic. There are a lot of personal and social barriers in accessing vaccination, which could be financial barriers or stigmas, and also the healthcare system barriers like a hostile medical system and insensitive registration procedures, which do not take into consideration their gender identity or chosen name. India's COVID vaccination is digitalized, and in that process, the gender registration does not have the transgender category. It has an others category, so you have been literally otherized. India, as a country, does not have a very literate trans population. Nearly half of the community is illiterate, and access to smartphones, which are needed for vaccine registration, were also difficult to come by. And we did not provide free vaccination in the early phase. Even right now, when we speak of booster doses, they are available only on paid basis in most of the states. And there are also a lot of incidental costs and opportunity costs that were often not taken into consideration. When we come to the research on vaccines and safety of the vaccines, no trials were done on trans and gender non-binary folks, especially those on ART or other forms of treatment like hormone replacement therapy. And therefore, that did not lead to a lot of confidence in the community when it comes to vaccines. The facilities were not trans-friendly. They did not have gender inclusive infrastructure, nor the staff was sensitized for the trans vaccine beneficiaries. And very importantly, there was complete invisibilization of the trans community when it came to the communication campaigns to motivate people to get vaccination. We must also speak about the solutions that did work later on, to a great extent. And one of them is visibilization of the community. So it's very important not to ignore the community and to provide specific services to them, to make the vaccination centers accessible. When I say accessible, not just in terms of infrastructure, but also services. Door-to-door vaccination drive did help a lot, especially when it comes to persons with specific needs, persons who were disabled, and also trans folks who could not travel to the vaccination centers. It was very important to involve the community, the non-governmental organizations, and very importantly, auditing by the community members for equity of the various vulnerable groups. And therefore, a constant process of course correction that was needed. We still have a long way to go, but just want to end this that, the measure of a civilization is how it treats its weakest members. And as far as the pandemic is concerned, or how we have tackled the pandemic, it's a great reminder of systemic discrimination that we have been doing and how that only got exacerbated during the pandemic. Thank you so much.
Thank you so much, Aksa, for being so to the time. So I open the floor to questions. We have, as I said at the beginning, our Q&A. There are some questions already, but we will leave some questions for the rest. So there is a first question for me. What can be done to reduce vulnerability due to the lack of protective equipment in Africa? Well, I think that what I tried to point out was that this idea that this is like a trigger, and that we should push and in a way try to require that this be given in adequate terms, as well as vaccination if it's possible, because if not, that will trigger vulnerability. There is another question or comment that says that the Belmont did not stigmatize, but it warned against invidious discrimination in selection of research subjects. And in a way, the concept of vulnerability, if it's treated as a subpopulation group, the idea, it's not the aim to stigmatize, but the aim sometimes is to protect. But in having this kind of concept, it might be too rigid to take it out. So, and as we were seeing with the different cases and scenarios that were shown, this may change. So the idea of having a concept that is more dynamic, it's more important. And I think that Dr. Tamara was pointing also to that. I think that in different ways, all of us were pointing to that. I don't know if these were questions more directed to me, but maybe the rest of the panelists want to to say something? If not, I can pass to the next question. There's to Professor Tom Shakespeare, there is a question. It says, what are your recommendations for the next pandemic? How can emergency and preparedness plans be more disabling conscious or inclusive?
I think the main thing is for disabled people not to be an afterthought. I think that, there's an emphasis, for example, in UK on older people and on the NHS, well, saving the NHS. So people with the virus are shipped out of NHS facilities into care homes where they seed the virus among other people in care homes. People who are employing their own personal assistants cannot get PPE, personal protective equipment. And I think all of these things show a lack of thought. So I think what we're asking for is disabled people to be considered alongside other people, because we're 15% of the population. So I think it is possible. It's nothing special, it's nothing different, but it's about inclusion in the plans.
Thank you, Tom. I have another question here for Dr. Aksa. It says, thank you for such an important study, Dr. Aksa. Do you have a sense of solutions which the trans community could identify themselves? Was the list identified by an academic group?
Yeah, thanks for that question, Mary. So in all the research endeavors that we have been doing with the two communities that we work for, that is the persons with disability and trans and gender non-binary folks, the approach is community-based participatory approach, where we look at the lived experiences of the research participants. So the research participants, as well as even the researchers who are part of the team, do bring in their own lived experience, and it's not therefore, the privileged folks doing research on the vulnerable communities. And even the current research that I highlighted, we have investigators who come from persons with disability, as well as from the trans and gender non-binary folks, and those who are allies with the community. So we do go for the community-based participatory research for creating these solutions. And it's still work in progress, so we could get back to you on the kind of solutions that the community has identified for themselves.
Thank you, Dr. Aksa. I don't know if Tamara, you want to say, I didn't find a specific question for you, but
that's okay.
Maybe you can add something.
Right. I think what I'd like to do is I'd like to clarify that I wasn't saying that all people are vulnerable. That is banal. What I was saying is that all people are potentially vulnerable, which is not to say that there are not people who are not more vulnerable than others. And certainly we found that to be the case in multiple countries. I mean, over 60% of the people that we ended up interviewing in our vulnerability assessment or vulnerability and resilience assessment were disabled. So, I think you're, I would agree with the fact that, yes, we do need to look at the epidemiological figures. We do need to look at, the kind of qualitative experiences, the ways in which institutionalization fragilized specific social groups within the population. But I would not say all people are vulnerable, because that's just downright silly. Okay, that's all I have to say.
That's wonderful, because I think that's the discussion that Tom was also pointing out. There is this idea of vulnerability as being something essential or universal, while there is this other idea of more thinking that it's something more related to the context, and also the context is what we are, no? So it's very interesting having this kind of discussion. I think we are running out of time, but we could do some work on this. I don't know if maybe we can finish with something from Tom, Aksa, some final thoughts in order to end this table?
So my thought is that when it comes to vaccination, don't forget disabled people. They may find it more hard to social distance. They may be in congregate living. They're almost always disempowered. So please remember disabled people in the strategies you develop.
Thank you, Tom. Aksa.
So my take-home message for folks, especially those who are monitoring the programs and services for the vulnerable groups, is to say that when we look at the data, which is segregated, for the vulnerable groups, for example, speaking of vaccination for the trans folks versus the other folks, or speaking of vaccination for persons with disability versus other folks, don't just go by quantitative data. That's important, but that should not be the only parameter guiding the policy making, but also look at the narratives from the community. How have been they able to navigate the services and the kind of, the experiences that they faced.
Thank you. Tamara?
Yeah, I would completely agree. As a qualitative anthropological researcher coordinating a study that is primarily qualitative, I think that we've run up against a lot of resistance on the part of national responders. They want numbers. And in fact, what's really important about the kind of work that I think that you're doing, that Tom has been doing, and in fact that my partners within Sonar Global have been doing, is that we're really humanizing and pointing out the really huge, both embedded and contextual problems, to borrow a phrase from Tom there. So I think that this is really important, and I look forward to interacting with all of you in the future.
Thank you. So my final thoughts would be that I do agree with what was shared by all the panel, that I think that also we have to think not only in some protections and giving, but also in empowerment, which is the new way of also thinking in vulnerability, not just protecting and having safeguard, but also empowerment and respecting people. So I think this is the spirit and this idea of layers that has this idea of compounding vulnerabilities and seeing how worse it can be if we have more and more vulnerabilities, layers that begin overlapping. So I think that it was a great panel, a complement between theory and actual practice and being in the trenches and living also vulnerability. So thanks a lot to all of you for being here. Thanks a lot to WHO, Catherine, Kevin, Catherine Little, Kevin Charles for organizing this seminar. And I think this is being recorded, and the PowerPoints and the citations of Tom were asked also in the chat. So I don't know if we can, through WHO, share them later. Thanks a lot for staying, and until the new epidemic ethics seminar.